The following podcast is part of a certified educational activity titled Mastering Diagnosis and Navigating the Sea of Targeted Treatments in Neuromyelitis Optica Spectrum Disorder, Practical Guidance on Optimizing Patient Care. Access the entire activity and complete the post-test at peerview.com/HXG860. Downloadable slides and practice aids are also available.
Welcome to Mastering Diagnosis and Navigating the Sea of Targeted Treatments in Neuromyelitis Optica Spectrum Disorder, Practical Guidance on Optimizing Patient Care. I'm Dr. Benjamin Greenberg, the Vice Chair of Clinical and Translational Research at the University of Texas Southwestern Medical Center in Dallas, Texas, for the Department of Neurology. I'm happy to be with you today talking about this program about neuromyelitis optica. Our goals for today are to review the diagnostic criteria for NMO so that you can promptly and accurately diagnose patients, understand the data and clinical rationale behind new and emerging treatments, and optimize your treatment for patients with NMO, adapting treatments to individual patient needs. Let's begin with the first module, getting it right the first time, overcoming the diagnostic challenges in NMOSD. The syndrome of neuromyelitis optica goes back well over 100 years, back to the 1890s when Eugene de Vic coined the term neuromyelitis optica when evaluating a patient with optic neuritis and transverse myelitis. His fellow, Ferdinand Galt, published his doctoral thesis, which included detailed clinical pathologic findings of Dr. de Vic's patient, and often this condition was referred to as de Vic's disease. Over time, there were controversies relative to the relationship between neuromyelitis optica and multiple sclerosis. Many individuals felt that NMO was a variant of multiple sclerosis. But with the recognition of molecular diagnostics that explain the disease, neuromyelitis optica spectrum disorder was separated out from multiple sclerosis as a distinct disorder. Over time, we have recognized that some individuals who share clinical features of neuromyelitis optica have unique antibodies, such as the anti-MOG antibody, that separates out this clinical spectrum of disease into subtypes. So what is neuromyelitis optica spectrum disorder? It's an inflammatory disorder of the central nervous system that's distinct from multiple sclerosis. While early on it was considered to be monophasic, it was rapidly recognized that relapses can occur. Core clinical characteristics include optic neuritis, myelitis, or area postrema symptoms that manifest as recalcitrant hiccups or persistent nausea and vomiting. Rarer presentations include inflammation of the brainstem, diencephalon, or the brain as a whole, and overwhelmingly it's associated with a specific autoantibody known as the anti-aquaporin 4 IgG. Over time, the diagnostic criteria for neuromyelitis optica has evolved from being a pure clinical diagnosis to one that incorporates supporting evidence from imaging and blood tests. In 2006, definite NMO was defined as an individual who had had optic neuritis, myelitis, and at least 2 out of 3 supportive criteria, one of these being the NMO IgG, also known as the anti-aquaporin 4 IgG. But as we learned more about this pathologic antibody, the criteria was updated in 2015 to recognize the critical importance of the aquaporin 4 antibody in making a diagnosis of neuromyelitis optica. And indeed, the diagnostic criteria for NMO is different for individuals who test positive for the antibody or individuals who test negative. And if you test positive for the anti-aquaporin 4 antibody and have had one clinical event, you can be diagnosed with neuromyelitis optica spectrum disorder. We'll talk about how we handle individuals who test negative for the antibody in a moment. But importantly, this criteria brings to light the need for early testing for the anti-aquaporin 4 antibody in patients who present with certain clinical syndromes. Lots of groups have proposed different recommendations and pathways and algorithms for making a diagnosis of neuromyelitis optica. One example was proposed by the NMOS group back in 2023. And it started, as we all do, with a history and physical of the patient. And if the history or physical points to one of these classic presentations, CNS inflammation of the optic nerve, the spinal cord, the brainstem, or the brain, then you must question the possibility of neuromyelitis optica as a defining diagnosis for those patients' symptoms. The first step would be to test for the aquaporin 4 IgG, and if positive, they meet the criteria for neuromyelitis optica. Additionally, you can obtain imaging, whether it's MRI of the brain, optic nerve, and or spinal cord, or OCT imaging to look for evidence of prior optic nerve damage. Spinal fluid analysis can be useful for looking for certain mimics of neuromyelitis optica. And indeed, a general and immunological lab workup may be obtained based on the differential diagnosis. For example, the anti-MOG associated disorder should be considered in these patients as well. Now, while the NEMOS criteria presents this in a way as a stepwise fashion, practically speaking, most patients will be getting these evaluations in parallel and not in series. For example, when sending the aquaporin 4 antibody, it is most common to send the anti-MOG antibody at the same time, because practically speaking, a lot of patients will get treatment in between the time their initial workup labs are sent and the results coming back. And we wouldn't want acute treatments to interfere with the test result. So indeed, a lot of patients get this testing at once, but importantly, in individuals where you suspect CNS demyelinating disorders, an aquaporin 4 IgG should be sent. Now, if you look carefully at this table, the NEMOS group recognized that not all aquaporin 4 IgG tests are the same. In parentheses, they listed the letters CBA, which stands for cell-based assay. The reason that the NEMOS group and indeed international panels suggest using the cell-based assay over ELISAs is from peer-reviewed literature that showed an improved sensitivity and specificity for the cell-based assay over ELISA-based assays. So indeed, when you have the option to get the cell-based assay, it gives you the best results for ensuring an accurate diagnosis of neuromyelitis optica. But not all patients with a phenotype that may look like neuromyelitis optica test positive for the antibody. And this brings up the dilemma of so-called seronegative NMO patients. Now, on this slide, what we're presenting is data about this population prior to the recognition of the anti-MOG associated disorder. And indeed, what we found in cohorts that were defined as having neuromyelitis optica clinically was that about 70 to 80% would test positive for the aquaporin 4 antibody, leaving 20 to 30% as negative. And we questioned, what disease do these patients have? Is it really NMO? Do they have a false negative antibody test? Or do they indeed have a separate disease caused by another antibody? Over several years, it was recognized that the anti-MOG antibody had overlap in a clinical syndrome with the anti-aquaporin 4 antibody, with patients in either group presenting with optic neuritis or myelitis. So this 20 to 30% of negative patients, those who test negative for the aquaporin 4 antibody, many of them have the anti-MOG antibody. But indeed, even testing for both antibodies leads to a group of so-called double seronegative neuromyelitis optica patients. These are individuals who have a phenotype that looks like that original Davix disease, but they test negative for the antibodies we've recognized. So what are some of the red flags in the diagnostic workup for an NMO patient that should make you look for alternate explanations other than NMO? Clinically, it is very rare for NMO patients to have a progressive course, and indeed some question if it happens ever. So if you have a patient with progressive neurologic deficits, it's a major red flag to look for alternate explanations of their condition other than neuromyelitis optica. Additionally, on the other end of the spectrum clinically would be an atypical time to attack nadir, meaning if somebody goes from normal to severely affected in under 4 hours, we should be looking for vascular causes of optic nerve or spinal cord pathology and not necessarily an inflammatory pathology. If you see comorbidities associated with neurologic dysfunction, such as cancer, chronic infection, or sarcoid, that should be a red flag to make you consider diagnoses other than neuromyelitis optica. And then there are lists of atypical imaging features, atypical brain findings or spinal cord findings that might cause you to consider a diagnosis other than NMO. And if you find yourself in this situation, what diagnoses should be on your differential list? And the answer really depends on the clinical symptomatology. In progressive disease, we might think about progressive multiple sclerosis. In individuals with longstanding chronic inflammation, particularly those with meningeal inflammation, you might think about sarcoidosis or even Behçet's disease. For individuals who have a mix of inflammatory and vascular pathology, vasculitis moves up on the list. And for those who have a history of cancer, you might think of paraneoplastic syndromes. So depending on the situation you're in, the workup might be different, but you always want to look for those red flags so that you broaden your differential, particularly for individuals who test negative for the aquaporin 4 antibody and who test negative for the anti-MOG antibody. Now, the most common or most prevalent differential diagnosis for NMO is going to be these three conditions. MOGAD, which is the anti-MOG associated disorder, the anti-aquaporin 4 mediated neuromyelitis optica, and multiple sclerosis. And on this table is a very useful comparison and contrast between these disorders that can help you think about them relative to the fact that they have an overlapping clinical spectrum of symptoms, but some distinct features both in terms of laboratory testing and imaging. For example, anti-MOG associated disorder can be seen in both children and adults. It can present as a monophasic or relapsing disease. The initial attacks can be quite severe, and it can present with bilateral optic neuritis. All of that can sound quite similar to anti-aquaporin 4 mediated neuromyelitis optica. But in anti-MOG associated disorder, when you look at the myelitis, often there is hyperintensities within the gray matter of the cord, and this would be unusual in the setting of multiple sclerosis or aquaporin 4 mediated disease. So if you look for some of the unique features that may differentiate these conditions, indeed, you can separate out cohorts accurately. But I must stress that this is just a guide and cannot be relied upon in all cases. We have been surprised in clinic by some individuals who I thought had multiple sclerosis, but indeed, when they were tested for the aquaporin 4 anti-MOG antibody, had glaringly positive results. Thus, some clinics, such as my own, recommend testing for the anti-MOG and aquaporin 4 antibody broadly in all individuals or near all individuals in whom you're considering a diagnosis of central nervous system demyelinating disease. Once you get an accurate and timely diagnosis for neuromyelitis optica, we then turn to treatment. And in Module 2, we're going to discuss the expanding treatment options in neuromyelitis optica spectrum disorder, leveraging new and emerging biologics to improve outcomes. Now, as we get started in this module, it's important to put this in historical context. Given the rarity of neuromyelitis optica and the fact that it was misconstrued as being related to multiple sclerosis for so many years, therapeutic options have lagged behind other conditions. But what we have seen in the last 5 years is truly an explosion in the number of options we have with high efficacy to manage this once fatal condition. And we are now in a point in time where we can offer a lot of hope and options to our patients for maintaining their health. But when talking about treatment, we first begin with the acute attack. Individuals who present to neurologists with neuromyelitis optica will often present with either optic neuritis or myelitis. And indeed, these attacks can be quite severe, and if not treated early and effectively, can leave lasting disability for our patients. It is standard of care to offer high-dose intravenous steroids to patients who are having an acute NMOSD attack. And in many centers, there is concomitant use of plasmapheresis or plasma exchange. Some centers use this in a staggered formation, reserving plasmapheresis for individuals who don't respond to intravenous steroids, but many centers, such as my own, offer it concurrently, particularly in patients who have a known diagnosis of neuromyelitis optica. There is data to show that the use of plasma exchange is superior than to steroids alone in treating acute attacks. Once the acute attack is handled and that inflammation is snuffed, then we move to the long-term goal in neuromyelitis optica of preventing attacks. In contrast to multiple sclerosis, the disability in neuromyelitis optica comes from incomplete recovery of clinical attacks. We don't see progressive disease in neuromyelitis optica. So there's a great opportunity to prevent disability in this disease by preventing attacks. Whereas in multiple sclerosis, even if we present attacks, some of our patients may progress over time. We do not see that in aquaporin 4 mediated NMO. And since every attack can result in permanent disability, we place a high priority on having effective and safe therapies for attack prevention. Now, until 2019, as I referenced, we were using off-label substances in order to prevent attacks in neuromyelitis optica. These included azathioprine, mycophenolate mofetil, rituximab, oral glucocorticoids such as daily prednisone, or even the off-label use of tocilizumab. And all of these were being used off-label based on open-label studies or retrospective studies. And it left us in a position where we had to make the best recommendations we could to our patients with very limited data. But since 2019, a lot has changed. There are now multiple biologics with FDA-approved labels, indications for anti-aquaporin 4 positive adults with neuromyelitis optica spectrum disorder. And the 4 drugs that have been FDA approved are listed here, along with their dates of approval. Eculizumab, inebilizumab, satralizumab, and the newest, ravulizumab, all have FDA indications for neuromyelitis optica patients. A couple important notes here. First, these labels indicate that they're indicated for anti-aquaporin 4 antibody positive patients, not seronegative patients. Secondly, in the US, these are all approved for adults with neuromyelitis optica, but globally, there are some agencies that have approved satralizumab for adolescents and adults based on clinical trials that included adolescents. But in the US, these are all approved for 18 and older. Eculizumab, inebilizumab, and ravulizumab are all infusible agents. Satralizumab is an injectable agent. The mechanisms of action for eculizumab and ravulizumab are the same. They inhibit complement, leading to prevention of attacks. Inebilizumab depletes B cells as an anti-CD19 monoclonal antibody. And satralizumab blocks the activation of the immune system by blocking the critical cytokine IL-6 from leading to B cell activation and ultimately disease. And when we think about these different treatments and we think about the pathophysiology of neuromyelitis optica, it's nice to put it in context. So here's a rudimentary cartoon of what we think to be the important players in the cascade of events that lead to an attack of neuromyelitis optica. We know that there is an interaction between B and T cells, and ultimately B cells will mature into plasma cells, producing the anti-aquaporin 4 antibody. That antibody crosses the blood-brain barrier, and or the plasma cell crosses the blood-brain barrier and produces antibody behind the blood-brain barrier. But when that antibody binds to the aquaporin 4 molecule on astrocytic foot processes, it leads to a cascade of events, including complement activation, recruitment of granulocytes, and ultimately a necrotic lesion. That differentiation of the B cell into the plasma cell and the activation of the plasma cell to make antibody is an IL-6 mediated event. Thus, these represent different therapeutic targets for preventing disease. You can kill the B cells responsible for the production of antibody and the activation of antibody production. You can block the cytokine IL-6 that leads to the activation of B cells, or you can block the complement. And this is where all of the drugs that have been FDA approved come in, either by blocking the B cells, the complement, or the activation of B cells through IL-6. Let's look at each of these drugs individually and review the clinical data that supports their use in neuromyelitis optica. And we're going to begin with eculizumab, the first complement inhibitor binding to C5 fragment that had an indication for NMOSD. So looking at the pivotal trial for eculizumab, the so-called PREVENT trial, we find that this was a randomized placebo-controlled study. It was double-blinded, but the randomization allowed patients to remain on background immunosuppressive therapy. So individuals could be on mycophenolate or steroids, and then they were randomized in a 2-to-1 fashion to layer on either eculizumab or placebo. Importantly, not all patients were on background therapy, but the overwhelming majority were. The primary endpoint of the trial was time to first adjudicated relapse. The secondary endpoints included the adjudicated annualized relapse rate, quality of life measures, and disability scales. But if we look at the primary outcome in the PREVENT trial of eculizumab, what we find is a separation of the curves early on in the first 48 weeks, with the placebo arm continuing to have relapses, but the overwhelming majority of the treated arm being relapse-free. Importantly, this highly effective therapy comes with a unique safety profile that clinicians should be aware of. Overwhelmingly, this was a well-tolerated medication. It's an infusion given every 2 weeks, but can be done rapidly and safely and even at home. But long-term, what we watch for from a safety perspective is whether or not the blocking of complement leads to an increased risk of infections, particularly with encapsulated organisms. There was one patient death in the eculizumab group to a pleural infusion and an empyema, probably related to an encapsulated pneumococcus. And indeed, the most important safety follow-up we do with eculizumab is looking for meningococcal disease over time. If we look at the long-term safety and efficacy of eculizumab beyond the pivotal trial, the open label extension of PREVENT went on for several years. The median follow-up was 133 weeks. And if you look at data from between 3 and 4 years, over 94% of patients were still relapse-free. And during the open label extension, just over a third of patients stopped or decreased the use of background immunotherapy. Data from this open label extension showed that when the original placebo arm converted to eculizumab, they were able to benefit from the same attack prevention that the patients who had been treated with eculizumab all along were benefiting from, with rates of 94, 95, 96% of individuals being free of adjudicated relapses. Importantly, during this time, additional safety data was gathered, and the serious infection rates were 10 per 100 patient years in the eculizumab-treated patients versus 15 in 100 patient years in the PREVENT placebo group during that first 48 weeks. There were no documented meningococcal infections, although as we follow eculizumab globally across multiple indications, not just neuromyelitis optica, but its other indication, paroxysmal nocturnal hemoglobinuria, we know that rare meningococcal infections can occur. Within the label, it is recommended and indeed required that patients get a meningococcal vaccination prior to starting eculizumab, and even with the vaccination, they should be followed closely for any signs of meningitis. Eculizumab brought to the world highly effective data for showing prevention of relapses, but there are other drugs that have also been FDA approved. Let's go to the second, inebilizumab, which is an anti-CD19 monoclonal antibody that leads to B-cell depletion. The N-Momentum trial had a different design than the PREVENT eculizumab trial. This was a randomized, placebo-controlled trial that was conducted in 25 countries and enrolled a whopping 230 patients who were randomized in a 3-to-1 fashion to inebilizumab versus placebo. Importantly, the blinded period after randomization lasted for 6 months, and the primary endpoint in this trial from day 1 of randomization was time to an adjudicated NMOSD attack. There were multiple secondary endpoints, including measures of disability, vision, MRI lesions, and hospital admissions related to underlying NMO. And importantly, patients could not be on background immunotherapy. So this was a monotherapy trial with no additive benefit from background mycophenolate or corticosteroids. The randomized control portion of the trial went on until there was a separation of the curves that showed statistically efficacy of the drug. And indeed, the endpoint was met with only 12% of treated patients having an attack compared to 39% of the placebo arm. During this trial, safety data was collected in this B-cell depleted patient population, and adverse events occurred in 72% of the treatment group and an equal 73% of the placebo group. Most of the adverse events included infusion site reactions or infusion reactions, but these were similar to those seen on the placebo arm. And serious adverse events occurred in only 5% of the treatment group compared to 9% of the placebo group. Importantly, there were 2 deaths that occurred in the open label period. One was not felt to be treatment related, and one in which test results were not available or ambiguous. Overwhelmingly with inebilizumab, as with all immunosuppressive agents, we're watching for infections. What did we learn during the open label extension of inebilizumab? What we found was after the first year of treatment, at which point over 86% of patients were relapse-free, when those individuals were followed for multiple years after the end of the trial, the overwhelming majority remained relapse-free. Of the original cohort, close to 83% were relapse-free multiple years after their first enrollment in the trial. But if you look specifically at those who made it a year to being relapse-free, well into the 95% range of those remained relapse-free. So this drug was highly effective, with most of the failures happening within the first 6 to 12 months. Now, often when we're talking about B-cell depletion in neuromyelitis optica, we think to the historical use of rituximab in an off-label manner. And the question is, how is inebilizumab different than rituximab? And it differs in two ways. The most obvious is it's a different target on B cells, specifically the CD19 protein compared to the CD20 protein on rituximab. This leads to a broader depletion of B cells with inebilizumab as compared to rituximab. But secondly, there is an engineering that has occurred in this monoclonal antibody that leads to a more robust depletion of B cells. And that's specifically an engineering to the FC portion of inebilizumab that allows it to overcome natural genetic diversity in our patients relative to B cell clearance. What is this genetic diversity? It's related to a polymorphism on the IgG FC region receptor 3A, known as the FCGR3A polymorphism. This is a genetic diversity that exists in about half the population, but importantly, it changes the way natural killer cells latch onto therapeutic antibodies and clear the cellular target. So for individuals who have one version of the FCGR3A gene, they will bind to rituximab in a less tight manner than they would bind to a glycoengineered antibody, such as inebilizumab. And this can have clinical implications. When we look to individuals who have the FCGR3A polymorphism, what we find for those who are treated with rituximab is a higher breakthrough disease rate based on an individual's underlying genetics. But when inebilizumab was glycoengineered to overcome that diversity, what we found was, regardless of a person's genetics, there was equal efficacy of inebilizumab. Thus, in these two important ways, both the antigen that the drug binds to and the glycoengineering of the FC portion, inebilizumab has two reasons to have a different effect on NMO than rituximab. Importantly, there have not been head-to-head trials, but there are open-label studies showing differential response rates. The third drug to achieve FDA approval for aquaporin-4 antibody-positive neuromyelitis optica spectrum disorder is satralizumab. This is a monoclonal antibody that blocks the IL-6 receptor. Satralizumab was actually studied in two different phase 3 trials. First, the Sakura Sky study. In this study, individuals were randomly assigned in a 1-to-1 fashion to receive satralizumab or placebo as an add-on to background immunosuppressive treatment, similar to what happened in the PREVENT trial with eculizumab. The primary endpoint was time to first protocol-defined relapse, and there were a variety of key secondary outcomes, including pain scales and functional assessments of fatigue. What did we see in terms of efficacy from the Sakura Sky study? Satralizumab was associated with a lower risk of relapse, but the pain and fatigue scores were comparable between the two groups. The rates of serious adverse events, including infections, did not differ between the satralizumab-treated group and the placebo-treated group. Indeed, almost 75% of patients were relapse-free on satralizumab at 144 weeks, compared to just 49% of placebo-treated patients. Separate from the Sakura Sky study, however, was the Sakura Star study. This was a phase 3 randomized controlled trial of satralizumab as monotherapy compared to placebo. So in this study, there was not background immunosuppression. Indeed, patients were randomized in a 2-to-1 fashion to receive satralizumab or placebo, and just like the Sakura SKY study, the primary outcome was time to first protocol-defined relapse. When we look to the Sakura SKY study, what we find is with add-on therapy, there were adverse events in a comparable rate compared to placebo. There were no deaths, and indeed the infection rate was similar between the two. How did this compare to what happened in Sakura STAR? So importantly, let's look at the efficacy first. 63% of patients treated with satralizumab in the Sakura STAR study were relapse-free at the end of 144 weeks, and only 34% of placebo patients achieved that same milestone. One of the questions is whether or not there was a benefit to monotherapy versus add-on therapy from a safety perspective. And indeed, if you look at the adverse event rates for individuals on monotherapy, you saw it was similar between those receiving satralizumab and those receiving placebo. The rates of serious adverse events were slightly higher in the treated group versus the placebo group, as were the higher rates of severe adverse events. There were no deaths, and while the infection rate in terms of absolute number was higher, due to the 2-to-1 randomization, the percentage of individuals with infections was essentially the same, particularly for those with serious infections. So even as monotherapy or add-on therapy, satralizumab had a very similar safety profile compared to placebo. This cohort has been followed over the long term, looking at both the efficacy and safety as part of an open label extension. When looking at the efficacy of those individuals treated with satralizumab, whether they started in the Sakura SKY or the Sakura STAR cohorts, what we found was overwhelmingly patients were receiving a clinical benefit and were free of relapses over 96 weeks or 192 weeks. Over the same period of time, safety data was collected and compared to what we see in post-marketing data. And what we find is that satralizumab has a percent infection rate of about 7.3%, a serious infection rate of 3.8%, and a rate of sepsis of 0.6%. Now, if you look at individuals with neuromyelitis optica in general, and you query a database for the rates of infection, serious infection, or sepsis, the rates in background neuromyelitis optica patient populations is higher than those treated with satralizumab, giving a hint that satralizumab is not increasing the risk of infectious complications in individuals who are treated for their NMO. Finally, we turn to the most recent approved biologic medication for neuromyelitis optica, and that's ravulizumab. Just like eculizumab, this is a complement inhibitor that binds to the C5 fragment, but importantly, has a different half-life. While eculizumab is a drug that is infused into our patients every 2 weeks, ravulizumab, due to its longer half-life, only needs to be infused every 8 weeks. How was this drug studied in trials? The CHAMPION-NMOSD trial did not have a standalone placebo arm. It used the placebo data from the PREVENT trial to compare to an open-label treatment of ravulizumab in 58 patients. For valid comparisons, the CHAMPION trial used the same design as a PREVENT trial to enroll and assess patients over time. During this trial, what was found was that 100% of the 58 patients treated with ravulizumab were relapse-free at the end of 96 weeks, compared to 52% of the placebo patients from the original PREVENT trial. This led to the FDA approving ravulizumab for aquaporin 4 antibody-positive neuromyelitis optica. Importantly, in the CHAMPION trial, multiple key secondary endpoints were examined, including the Hauser Ambulation Index and multiple disability scores. And what was found over time was that individuals treated with ravulizumab had a protective effect, such that their Hauser Ambulation Index and their disability scores did not worsen, whereas placebo patients did have worsening over time. Furthermore, when we look at the safety of ravulizumab from the CHAMPION-NMOSD trial, we find that its safety profile is very consistent with eculizumab. And indeed, the indication and the label for ravulizumab cites that we should watch for encapsulated organism infections, such as meningococcal infections. Indeed, there were 2 cases of meningococcal infections in patients in the CHAMPION trial, both of whom had already been vaccinated for meningococcus. This just serves as a reminder that when inhibiting complement, we have to watch carefully for infections due to encapsulated organisms. If we look at the ongoing phase 3 CHAMPION trial, the long-term extension, we see in the interim analysis that there have been no adjudicated on-trial relapses in the ravulizumab-treated patients. Over 91% have had stable or even improved Hauser Ambulation Index, and there have been no events of clinically significant worsening of disability scores. The treatment emergent adverse events occurred in 94% of patients, with serious events happening in over 25% of patients. Most of these were mild to moderate in severity and unrelated to ravulizumab. Since the 2 patients early in the course of the trial, there have been no other documented cases of meningococcal infection, but this cohort continues to be followed. So now we exist in a world where we have multiple FDA-approved therapies for neuromyelitis optica spectrum disorder. And importantly, as a reminder, these are all approved in the United States for adults who test positive for the anti-aquaporin 4 antibody. These are not proven to work in seronegative patients or those with the anti-MOG antibody. Thus, for the purposes of the rest of this conversation, we're going to focus on patients who are aquaporin 4 antibody positive patients. And it brings us to module 3. How do you navigate the treatment decisions in neuromyelitis optica spectrum disorder? We've moved from a world where we had a variety of off-label therapies that had been studied in an open-label or retrospective fashion, and in whom the data supports the fact that there was an efficacy signal. We just can't quantify it. Into a world now where we have 4 FDA-approved therapies that have gone through various versions of rigorous randomized trials in order to gather both efficacy and safety data. And so it leads us to ask the question, how do you pick an individual drug for an individual patient? As you might suspect, there are no universally accepted algorithms when picking a therapy for an individual patient. And it's extremely important for all of us to engage in a shared decision-making model with our patients so that they have faith in the ultimate drug that they choose to use as a preventative in neuromyelitis optica. We're also well aware that there are multiple of third-party payer limitations on our drug selections. So when talking to patients, it's important to help them navigate the decision they have to make based on the pros and cons of each drug, but remind them that once they pick a top choice, they may have to have a second choice if their third-party payer denies coverage for the individual drug. But how do we help patients choose among the therapies, and how do we compare and contrast them for our patients? There are lots of ways to do this, where we can talk about the advantages and disadvantages of drugs, and we can also differentiate them based on their route of administration and frequency of administration. If we talk about eculizumab, the advantages include it has a rapid onset, a sustained effect, and very high efficacy. The disadvantages are the potential for opportunistic or serious infections like meningococcus, the high cost associated with it, and the frequency of administration, an infusion every 2 weeks. Ravulizumab has the same advantages as eculizumab based on its mechanism of action, but it has a less frequent administration. So you go from every 2 weeks to every 8 weeks, but the risk and the cost stay essentially the same. So for some individuals, they may feel the risks are too high, or their insurance may or may not cover it, and they may look for other drugs to compare to. Satralizumab and inebilizumab are the 2 other FDA-approved therapies. Satralizumab stands alone in the fact that it's not an infusible therapy. It's a self-administered injection, a subcutaneous injection, that patients are taught to give themselves at home. It can be combined with other therapies and has data relative to its safety for long-term immunomodulation. Now, while there have not been head-to-head trials between any of these drugs, the data from Sakura Sky and Sakura Star did not have as many patients relapse-free by the end of the trial. It is very difficult to compare these trials due to different inclusion-exclusion criteria and different definitions of relapses. Thus, as we stand here today, we cannot firmly say if satralizumab is as effective as the other three FDA-approved therapies or if it is slightly less effective. In general, I put this on a relatively equal playing field relative to efficacy. Importantly, the safety data, particularly around infections, has remained quite promising for satralizumab. One disadvantage, however, for satralizumab is due to its self-administration at-home feature, compliance and adherence is less easily monitored than that with infusions. And it brings us to the last drug that's FDA approved, inebilizumab. Advantages include its ability to reduce B cells that are responsible for producing the aquaporin 4 antibody. The dosing interval is once every 6 months, which is quite easy for patients to do. It has a familiar mechanism of action and hence safety and efficacy profile to B cell depleting drugs we've been using for years. And it has good long-term efficacy data. The disadvantages include a potential longer latency to action. If you think back to that end momentum trial, the majority of breakthrough disease happened in the first 6 months, suggesting that we may need additional therapy in the first 6 months to protect against that breakthrough. That has not been proven in prospective trials. So how do you take all this information and navigate the treatment decision? So there has been groups, and we'll refer to our colleagues again in the NEMOS group, who have put out a potential algorithm for choosing drugs to prevent future attacks. And they listed first choices for an aquaporin 4 positive NMO patients, including all of the FDA-approved drugs and rituximab in an off-label fashion. Secondary choices were felt to be other older immunosuppressants that had not had as strong a data set. If an individual has breakthrough disease on one of these drugs, then there's an algorithm for choosing the next. But it's important to note that this has not been studied prospectively and just gives you a guide for consideration. Indeed, failure of any of the first-line drugs does not necessarily mean you can't switch to another. If you look to the international community for any consensus statements about the management of individuals with aquaporin 4 positive neuromyelitis optica, you find that there are recommendations around best practices in management and also recommendations around how to think around these drugs. In one study that used a Delphi consensus approach to ask questions to a panel of experts about the management of patients, what we found was a high rate of agreement around certain statements. First, when asked about therapies that could be initiated at the time of diagnosis after a first attack or after a relapse due to treatment failure, 78% said eculizumab would make the list, 100% of individuals said inebilizumab would be on the list, and close to 95% said satralizumab would be on the list. Importantly, at the time that this study was done, ravulizumab had not yet been approved, and the likelihood is it would be considered very similar to eculizumab. Importantly, this committee was also asked a series of statements to try and build consensus, and indeed 100% of individuals responding said the most important factors when picking a therapy were a balance between efficacy and safety. Also important was current clinical disease activity, relapse severity, acceptability of route of administration to the patient, and whether the therapy might benefit a comorbidity. Additionally, in a newly diagnosed patient population, you have to consider the patient preference for dosing frequency and route of administration. Indeed, this group was supporting the use of that shared decision-making model when trying to pick a therapy for our NMO patients and in collaboration with our NMO patients. And indeed, 89% of this panel said that if a patient was free of relapse or tolerability issues on an off-label immunosuppressant or biologic, meaning they're in your clinic and they've been treated for years but they're stable, there was not a need to switch them. This is something that is receiving intense scrutiny in prospective studies, but to date the consensus is if it's not broke, we're not fixing it. This, however, still needs to be discussed with patients, as they need to be aware there are FDA-approved drugs to choose from that may have a different set of data than the older drugs that we were using in an off-label fashion. So after all of this, where do we conclude? First, it's important to remember that each and every NMOSD attack can result in irreversible neurologic injury. It's important to make the diagnosis quickly and accurately. It's important to treat relapses quickly and completely. And it's important to diagnose people by utilizing the Aquaphor antibody diagnostic test. After you've treated the first attack and made a diagnosis, quickly pivoting to the initiation of long-term maintenance therapy to prevent future attacks is important, but picking that therapy depends on a shared decision-making model with your patients, where they can understand the pros and cons of each of these therapeutic options and make a decision that will be best for them. In closing, I want to thank you for participating in this educational activity. I hope you find it useful in your practice. Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Genentech, a member of the Roche Group. To access all materials for this activity, visit peerview.com/HXG860.